Hello, Mama. Ndazoita pregnancy test yefuti. Mama ina ndichazivi. Mama ina ndichazivi. Sizvamurikuona. It came out negative again, Mama. Kichingani, Mama. Kichingani, Mama. Mama, inandichazivi. I've tried everything, Mama. Nenda kuchechi ndanamatirwa, Mama. Nenda nemafriends angu kumaprofits. Zvaramba, Mama. Mama, ndatraya, Mama, kumwa zvinhu mazai zvimaavhu mishonga zviri kuramba, Mama. Inini, Mama, handichazivi. But these are the latest results, Mama. Zvakurwadza izvi. Handichaziva kuti ndoita sei nemama ini. Ndaifungawo kuti ndagona ndikachatawo sevamwe, Mama, asi zviri kuramba. Mama, zviri kurwadza, handichazivi kuti ndoita sei.
Dear doctor, I'm a lady aged 31. I got married a few years ago. I've not been able to conceive. I tried the medical route but did not go far because people told me that this was spiritual. I've tried both the traditional and Christian ways to assist me to conceive, but I have failed. I'm really getting worried about this, but people are saying if I worry, it reduces my chances of conceiving. Is there any medicine or foods that I can take that can help me to conceive? Can you really help me to understand more about this condition?
Well, the definition of infertility is a clinical definition. It's basically a definition that describes when we start getting worried about a couple who are trying to conceive. It's basically in two forms. One, a couple where the lady is less than 35 years. We start getting worried about their failure to conceive if they've been trying for a period of 12 months with regular intercourse and no contraception. And if a couple, the female partner of the couple is more than 35 years, we start getting worried about their failure to conceive after a period of 6 months of regular intercourse without family planning. If a couple has previously conceived and they're failing to conceive, they basically will call that secondary subfertility. There are quite a number of cases which can affect the female partner and the male partner to lead to secondary subfertility. In the female partner, basically the major cause is when you've got blockage of the tubes or any abnormalities occurring on the uterus. What happens sometimes is that a normal female partner who has been having a normal uterus and normal tubes can get tubes blocked through a number of different processes, major one being infections. For example, if they've got an infection, the tubes can get blocked, or they can have problems occurring on the womb itself. For example, you get people developing fibroids. That can actually lead to abnormalities of the uterus, which then makes it difficult for them to conceive. Sometimes also female partner can have problems to do with ovulation, whereby they develop medical conditions that affect their hormones, and they therefore end up not being able to ovulate and therefore not be able to conceive. Then on the male partner, usually we have got this preconceived idea that a man doesn't finish. You have kids until he's 70 something, 80, or until he dies. There are conditions that can occur on the male partner that can actually make them have difficulty in being able to be a father when they have previously been having kids without any problem. Top of the list, for example, is diabetes. Diabetes will certainly affect spermatogenesis. So, if, for example, if the diabetes is not well controlled, the male partner will then begin to struggle to produce sperm, and some infections can cause blockage in the tubes that allow the sperm to move from where they are produced to ejaculation. So both male and female partners can have secondary subfertility. We have to do investigations on both the male and the female partner. On the female partner, when we are targeting the tubes, there are two tests that we usually do in this country. They are basically tests that check that the tubes are still open. One of them is a test that is done through x-rays, where they pump a dye from below and then take x-rays to see that the tubes are open. And then another one is where we take you to theater and do minimum access surgery called laparoscopy and dye. Basically, it's the same. We put a small telescope below the umbilicus, visualize the uterus, put the dye from below and see whether it spills. There are other different ways of doing the same thing, but that's the main test that we do if we think that the female partner has got tubal problems. We also, on the female partner, do tests to check that the hormones are well balanced, to check again that she's still ovulating. Sometimes the female partner will gain weight and start developing other conditions that would make a not ovulate. So we've got blood tests and other different types of tests that we do to check that. Then on the male partner, the main test that is done obviously is the semen analysis. This is whereby the man gives us the sperm. Then we look at the different parameters on the sperm, mainly to check the number. Number two, to check the function. That means are they moving, the sperm moving properly. And then number three, to check the appearance. That forms like the basis of the test. If the semen analysis is abnormal, then we go on further to check other different types of causes for that and see what we can treat. If someone is not conceived, we basically call that primary subfertility. The main one, usually when we look at subfertility, we look at it in the form of whether it's a male factor, female factor. Sometimes we get combined, where you get male factor and female factor being there, and then you have a situation whereby you can't explain it. The man is normal. The female is normal. That's called unexplained subfertility. In the female factor, you're looking at problems to do with ovulation. You find that a woman will not be ovulating, and they'll be going for months and months without having their period. That's usually a warning sign that they are not ovulating. And then there are other problems to do with the tubes on the woman. Maybe in early sexual encounters, the tubes become blocked for whatever reason. So that's one of the causes for primary subfertility in the female. Then in the men, you have problems with production of sperm, either leading to total absence of sperm, which is called azoospermia, or a situation whereby the sperm is reduced, which is oligospermia. And then you also get men that are producing sperm in the correct proportions, but they are not able to release the sperm, right? Instead of releasing the sperm forward, the sperm goes back to the bladder. That's called retrograde ejaculation. And then you also have men that cannot maintain an erection, and therefore they're not able to penetrate and produce the sperm. So that we then investigate on the men to find out what the cause is, and then treat appropriately. period pain is a symptom. It's a symptom of a condition. And the condition that usually causes people not to end up having able to conceive, that causes period pain is what we call endometriosis, right? So patients with endometriosis, they have severe period pains, right? So the period pain itself is not the problem. The problem is the endometriosis or other causes of period pain, which are contributed by pathologies in the womb. You've got lots and lots of problems that can happen in the womb that will come out as a period pain. So the pain itself is not the problem. The problem is what is causing the pain, and sometimes that does contribute. A significant proportion of women that are obese, for example, have problems with their hormones, and they can actually be obese because they've got another condition. For example, they're diabetic, they've got polycystic ovarian syndrome. So the condition that is causing them to be obese is one then that disrupts the fertility. So you find that, for example, a patient who's got polycystic ovarian syndrome will come and we see and we assess that no, the obesity is now contributing to her having imbalanced hormones, and therefore she's not ovulating. She should lose weight, and then everything goes back to normal. Not permanently. Temporal. For example, if you're using Depo, the one that is given every 3 months, when you stop using it, it can continue working in your system, maybe up to 6 months. That's what we call return to fertility. So because it's an injection, it's a long-term injection, it can continue working in your system up to 6 months, and then you think that there's a problem. But when it wears off from your body, usually no problem. Yeah, certainly they are not scientific proven. Some of them are actually even harmful to whoever is taking them, and they don't have a dosage. They don't have a mechanism of action, and some can actually even cause other damages. For example, kidney failure, which can worsen your subfertility issues. Some are put down there, which can actually even block the tubes themselves, even if they were open. So we don't encourage people to use this. We allow people. We think that is a good thing that people can pray, because God does bless couples with children. But after prayer, it's better they come to the scientific side of approach. Okay, so that's a very broad question, but let me try and summarize and say, if, for example, the woman is not ovulating, the main cause being what we call polycystic ovarian syndrome, we check other pathologies to see if it's just ovulatory problems. For example, we also double check that the tubes are open and the male factor is fine. So if it's just a question of being unable to ovulate, we do stepwise treatment. First, we probably start with ovulation-inducing agents. I'm sure people will talk about them as being fertility drugs. Those are drugs that we use to cause the woman to ovulate. And if that fails, we go a step further. We use injections to cause them to ovulate. And if that fails, we go on a step further to give what we call intrauterine insemination. This is a situation whereby the woman is given medication to produce an egg, and then the sperm from the female partner is cleaned and introduced into the womb. There are two main conditions for that. One, the woman's tubes must be open, and two, the sperm must be normal. If that doesn't exist, if the tubes are blocked, the sperm is not normal, then you go on to what we call IVF. Now, in IVF, what we're doing basically is we give the female partner medication to produce eggs, and then we take the eggs out of the body to the lab. Then we take the male sperm, clean it up, and then we fertilize it outside. And then we then transfer a fertilized egg into the woman's to the woman's womb. In terms of the actual process of IVF, you're looking at about 2 weeks of injections on the lady, and then fertilization, and then another week, and then transfer. So it's about 3 weeks, and throughout that process, you're not admitted. Right? You're having injections coming from home if you're having them with the clinic, or if you're having them at home, you're having them at home. So you'll be going to work for those times that you'll be having your injections. You'll be monitored using scans, which takes about 30 minutes. So your life is usually not disrupted. The only time that you go to theater is just a day, and it's a day procedure, and you are not admitted as well. So it's 3 weeks of outpatient care. It's not like it's something where you're going to be in hospital for 3 weeks. No, it's 3 weeks of outpatient care. If the tubes are blocked, these days we no longer recommend opening of tubes, because it's an operation that is very difficult, and also it's got very poor success rate. So we usually recommend that people go straight away to IVF if there's a question of the tubes. Then on the male side, usually if there's a problem with the male, for example, let's talk about the worst case scenario when the azoospermic, we have to investigate and see the lack of sperm in the ejaculate, whether the sperm is being produced but it's not coming out from a blockage or whatever. If that is happening, we go inside the testes and get the sperm, and then over that couple IVF. If there's oligospermia, we can use that sperm to do IVF and ICSI. For retrograde ejaculation, that is the one who's not producing the sperm, but the sperm is going back to the bladder. We can get the sperm from the urine, or actually give drugs so that that is reversed and the person produces the sperm from the urethra. Then further, there are some women, for one reason or another, who cannot produce eggs. Maybe age-related. Some people might have an operation and they removed all the ovaries, or someone maybe is old for us, 40 and above. Even if you give them drugs, you're not able to produce eggs. Those then have got another option. That's an option of getting a donor egg, being fertilized with their male partner, and then they carry the baby. Right? And then you get situations also where the female partner still has her eggs, but the womb was removed. Maybe during childbirth, which is most people during childbirth, something happens and start bleeding, and the doctors, to save your life, they remove the womb and they leave the eggs, and they think that, no, I won't be able to have a baby. That is not true. That's where what we call surrogacy comes in. So what we do is we stimulate the lady, and she produces eggs. We remove the eggs, and we fertilize the eggs with a partner, and then she gets someone else to carry that baby. And that baby is her baby because it's her eggs and her partner's eggs. So they have to make an arrangement that when the baby is born, and then the baby can go back to the genetic mother. That's called surrogacy. In Zimbabwe, it's unfortunate that fertility care is out of pocket from the patient. In other countries, this is supported from national insurance, for example, in NIH in the UK and things like that. People go through this treatment for free. So as fertility specialists, what we do, we do a stepwise approach, because As you get more complex tests, the cost becomes higher. So the best line, for example, on a lady will be a hormone test to check the hormones, to see that the hormones are balanced. And then also a test to check the tubes. That forms like the baseline. And then on the men, the baseline again is just to check the sperm, to see that there is sperm, right? If there is sperm, then you're fine. If there's no sperm, then you can move a step further and do tests like hormones to check if, for example, the lack of sperm is a primary problem in the testes or somewhere else. So we do stepwise. The cost is a bit high when you get to the more complex tests, but the initial tests are not that bad. When there's subfertility, a lot goes wrong in terms of the psyche of the affected couple. Sometimes you get a situation whereby one partner blames the other, and most of the time it's the man blaming the woman. They always think that the woman is to blame. When, for example, you look at the statistics, you find that the distribution of causes of subfertility are 50-50 from both men and female. So most of the time, the man also has a problem. But it affects the woman, it affects her confidence. When you go to family gatherings, people don't treat you with respect. They say, go and they give you chores that are given to young girls, and people talk behind your back. And even at work, the same thing happens. People don't look at you as a woman. They say a woman means you must be a mother, things like that. And then also the same effects then happen on the men's side. Guys don't respect you. They say all lots of things behind your back, and that affects your confidence and the way you perform and the way you achieve things and things like that. And the big part is that the relationship itself between this couple starts to have problems because of subfertility. We get a lot of calls. I get a lot of calls from subfertile couples, and usually, if you look at the calls, there are calls that are made when people are now at home and sitting and comfortable. That's when people start talking. Why don't we have a kid? Why didn't you go and see a doctor? And they start pointing fingers at each other. So we get a lot of marital problems arising from that. And as a consequence, also we get a lot of gender-based violence arising from that. And then you also get a lot of infidelity. For people who don't know or don't want to go to the doctor to be tested, they test themselves. They go and have another relationship with someone else to check if I can make her pregnant or I can get pregnant. And that introduces a lot of problems, because the marriage then begins to crumble and maybe an infection sets in and you have all these sort of things. But we are saying that shouldn't be the case. Of course, it's expensive, but it's not an urgent thing that someone is bleeding just to be done today. If you save for it and go together as a couple, you'll be surprised. Sometimes some of the problems are not major problems, and then you can be assisted, and then your family can be built. We've got patients that have 2, 3, 4 children from the assistance that we give. It's not necessarily IVF, sometimes even just ovulation induction, and someone has got a complete family, and they're happy. So the psychological effects is major. There's more psychological problems than even anything else. Baby is made by a family, a couple, a man and a woman. So before, for a long time, right, men will not come. Even now, men don't come. They send the wife, and she comes and says, we've been failing to have a child for 6 years. Can you check on me? And then you check on her, find out there's nothing wrong. And then to get the men to come then becomes a problem. So it's much better if people come together and we check both of them. And we have got support systems that actually help, and people don't blame each other, because the blame culture also becomes a problem. If the two individuals have proposed to each other, they're married to each other, they've been staying for 5 years, and they just have this problem of not having children, if we solve it, life goes on. So they come, if they come together, it's much better. Even if the problem is one person, the other can actually, in terms of, it can help in terms of psychological support. But investigations are supposed to be done on both, because the causes for subfertility are 50-50, men to female. Well, the only advice is that there is now, in both cities, Bulawayo and Harare, there are now clinics, even if they are private clinics. If one is struggling to have a baby, a couple is struggling to have a baby, go and see your usual doctor. And if the usual doctor is not able to assist you, you can request that, can you refer me to the specialist, a gynecologist who probably do the tests that are required. And most of the time, the ordinary gynecologist can actually treat some of the things. And usually, if the ordinary gynecologist fails to solve this problem, that's when then they refer to subspecialists. So the message is, instead of people blaming each other, they should go and see their doctor, who will be able to institute investigations and will be able to tell them what needs to be done. You'll be surprised how many people come to see us after 15 years and say, I didn't know that I can be assisted in my own country. Or I didn't know that there's this kind of help that can happen. Right? They just been told by prophets and all these other people that this is like this is like that. Whilst praying is important, I think science should be given a chance to help these couples.